A medical treatment for COVID-19 worth consideration. Video number 1. My name is Dr. Jwala Prasad, and I would like to share with you my experience with a combination of medications that has helped patients with COVID-19. This combination of medications was designed based upon scientific studies and was given the name AFA therapy. This medical treatment may save hospitalizations and maybe even some deaths. This video is for informational purpose only. All opinions expressed, even though scientific, should not be considered as recommendations. The data presented is observational and anecdotal. The contents in part or in their entirety, if used by the viewer for any other purpose, is at the sole responsibility of that viewer. If the information provided is used for treatment, results are not guaranteed. It is impossible to present all the details about coronavirus and the treatment of a complex disease like COVID-19 in a single video. Therefore, you need to watch this and other videos to understand AFA therapy, the rationale behind it, and the experience so far. The scientific fundamentals that are the basic of AFA therapy will be discussed with appropriate references in the next video. The main goal of sharing this data is to help people worldwide, especially those who cannot afford PCR tests, doctor's fees, or cost of hospitalization. Sometime in the near future, especially for those who cannot get or afford a PCR test for COVID-19, a free medical application will be made available that might help them make their own decision about COVID-19 and the treatment. Before diving into the details of AFA therapy, let's discuss the fundamentals of coronaviruses and COVID-19. There are many coronaviruses in the world. 15% of common colds could be caused by coronaviruses. The severe acute respiratory syndrome pandemic of 2002 to 2004 was caused by SARS-CoV-1 coronavirus. The Middle East respiratory syndrome was caused by MERS-CoV coronavirus. The current pandemic is caused by SARS-CoV-2 coronavirus. This also causes severe acute respiratory syndrome. The illness or disease is called COVID-19. COVID-19 started in Wuhan, China in December 2019 and is now a pandemic. As of January 25, 2021, the total number of cases worldwide is reported as 99.8 million, which is almost 100 million, with total number of deaths over 2.1 million. The total number of cases in United States alone is over 25.7 million, with total number of deaths reported as over 429,000. Coronavirus mutates like other viruses do. Some important mutations are from Brazil, United Kingdom, and South Africa. These variants or strains are supposedly more contagious and could be probably deadly. If mutations are significant, then testing, treatment with monoclonal antibodies, and prevention with vaccines may or may not work. Frequent reinfections are possible. In order to understand the treatment like AFA therapy, we need to first understand how the coronavirus invades the human body. In the early course of the infection, which is called phase 1, the disease is primarily driven by replication or multiplication of the virus. During this period, which may last 1 to 6 days, the virus is multiplying and moving from the nose, mouth, throat, trachea, main airway, smaller airways, and in the blood. The immune system in the body tries to stop the virus at different levels with the built-in defenses it has. The degree of response and the timing depends upon the amount of virus, which is called the viral load, that is invading, and the state of health of the immune system. If the immune system is unable to stop the spread of the virus and damage to the cells, the illness enters phase 2. In this phase, which may start around the 6th day or a little later, the virus reaches the alveoli or air sacs in the lungs, and the disease is driven by an exaggerated immune and inflammatory response to the virus. It is called cytokine storm. It is believed that bradykinin, which is also a chemical like the cytokines, could be responsible for this inflammatory process. This, along with increased blood clotting, leads to tissue damage in the lungs and other organs. This results in pneumonia, difficulty in breathing, low oxygen levels or hypoxia, respiratory failure, and death in some. Recovery does occur with proper treatment if damage is limited. Autopsies have shown pneumonia in the lungs and blood clots in the lungs as well as other organs. Let's talk about what should be our treatment objectives for COVID-19. Of course, stopping the virus from spreading, which is prevention, should be the first step. I will discuss about prevention in another video in detail. Going to treatment plan, we should know that there is no antiviral agent or medication to kill the virus or stop it from multiplication. Vaccination is not a treatment. It is for prevention, which may not be adequately achieved with the current vaccines for 2 to 3 weeks after the second shot, which means 6 to 7 weeks after the first shot. So if there is no antiviral agent except for monoclonal antibodies or convalescent plasma, we should consider other therapies or treatments. AFA therapy is worth considering given the low cost, easy availability, and limited choices we have under current circumstances. Where does the AFA therapy fit in? Currently, we do not have an antiviral medication for COVID-19. Progression from phase 1 to phase 2 may occur in a patient silently and rapidly while at home. This is the vulnerable period, at least that's my opinion. Phase 1 and phase 2 could be overlapping. Therefore, early treatment is the best choice. Worsening condition requires hospitalization and increases the risk of death. Starting AFA therapy immediately might prevent worsening of condition and hospitalization. So, what is AFA therapy? AFA therapy includes azithromycin, famotidine, and aspirin. Famotidine also goes by the name of Pepcid. I will discuss in detail later in this video the AFA protocol or treatment. The scientific basis of this combination of medications is discussed in another video. Azithromycin, famotidine, and aspirin individually have been studied in various settings for COVID-19 treatment, and some studies are being done or proposed. No controlled study has been done so far with the above combination in an outpatient setting worldwide to the best of our knowledge. The above medications work in synergy because of their combined effects, which is beneficial. The cost of the above medications is minuscule in comparison to other therapies for treatment or prevention. How did it all start? It is an interesting story. I'm a cardiologist in the United States of America, but to my family and friends, both here and in India, I have been their medical advisor and doctor for years. This responsibility forced me to stay abreast in other areas of medicine besides cardiology. I have practiced telemedicine on phone and by video calls for several years. The COVID-19 pandemic presented a special challenge for me to take care of my loved ones. Sometime in March, April of 2020, as the lockdowns were starting all over the world, I advised my family and friends, especially in India, to make sure that they have the AFA medications and a pulse oximeter available. In the summer of 2020, as more data on COVID-19 started to come in, a protocol was created to use it as a template with some modifications if needed for patients with pre-existing conditions or comorbidities. Before the Emergency Use Authorization or EUA of monoclonal antibodies, I have personally treated 10 patients with this protocol with success. 6 of them are in India and 4 are in the United States. Since my specialty is cardiology, I discussed the AFA protocol with my nephew in India, who is a medical doctor. His name is Dr. Rajiv Prasad, and he practices in Hyderabad, India. Between August and December of 2020, he has treated at least 400 patients using AFA protocol. These patients were treated by him by telemedicine for symptoms of COVID-19. All the patients being discussed were treated as outpatients or at home. They all had symptoms consistent with COVID-19. Majority of patients could get a PCR test. Others did not want to go to the government hospital for a supposedly free test due to fear of getting worse or sicker. All PCR tests done were positive. Follow-up appointments in India are at the will of the patients. Patients were advised to return in 1 to 2 weeks or sooner if any problems occurred. Patients were also advised to go to the hospital in case of emergency or worsening condition. None returned for follow-up. Therefore, it is assumed that all patients did well. Patients could not be contacted directly due to practice restrictions. The data being presented is retrospective and anecdotal. The data was collected informally. The age range was 30 to 80 years, and 60% were male and 40% were female patients. The pre-existing or comorbid conditions included hypertension, diabetes, history of documented coronary artery disease. The symptoms were fever in 95%, cough in 90%, sore throat in 50%, muscle aches in 50%, weakness in 50%, and loss of sense of smell or taste in 20% patients. All patients over the age of 45 years were prescribed AFA therapy, vitamin C, and paracetamol or acetaminophen. Those younger than 45 years were prescribed the same medications except aspirin. Approximately 7 patients with high fever and shortness of breath were prescribed above medications but urged strongly to go to the hospital. Full recovery was assumed with no residual symptoms or complications. Follow-up could not be done properly. As a cardiologist, I do not practice family medicine or internal medicine. Still, I ended up treating at least 10 to 12 patients, mostly from India, on telephone using WhatsApp. A few patients I treated in the United States were also on AFA protocol, and this was long before monoclonal antibodies were available. I want to present an interesting case with oximetry to you. The patient lives in India, was managed by me from USA using WhatsApp. This is a 62-year-old female patient with hypertension, coronary artery disease, and diabetes with COVID-19 symptoms. She had fever of 100 degrees Fahrenheit the first day with scratchy throat, dry cough, and body aches. Was advised acetaminophen or Tylenol and to continue her cardiac and other medications, including aspirin 75 milligrams. Patient was advised PCR test but did not get it. The next day, the fever increased to 102.2 degrees Fahrenheit. The patient was advised to check oxygen level using pulse oximeter in both hands. Oxygen level was 88%. The repeat check was the same. However, she did not have any complaints of shortness of breath. This is an interesting phenomenon in COVID-19. I advised her daughter, who was assisting her and who was healthy, to check her own oxygen level. It was 99%. Patient was therefore advised to go to the hospital if condition worsened, and AFA therapy was started. She was also advised self-isolation. The patient was advised to take azithromycin 500 milligrams immediately and started on famotidine 20 milligrams twice daily. She was already on aspirin. Her CBC showed a decrease in lymphocyte count. Over the next 24 hours, her temperature decreased to 99 degrees Fahrenheit and the oxygen level improved to 90%. After 48 hours of initiation of AFA therapy, her temperature was 98 degrees Fahrenheit and the oxygen level was 92%. She became mostly asymptomatic 72 hours after the initiation of AFA therapy. Her condition returned to normal on the 7th day with normal temperature and an oxygen saturation of 97%. Only one Z-Pack was used. Famotidine was continued twice daily for an additional 7 days, and aspirin was continued as before. She has had no ongoing problems in the last 2 months. What I have presented is anecdotal evidence or observation, and this is not from a controlled study. What started as an informal protocol over time became a template for us to treat patients with confirmed or suspected COVID-19. Good outcomes led to some record keeping, and the data being presented is what it is. AFA therapy is not approved or endorsed by any institution. The main goal of sharing this data is to help poor people worldwide, especially those who don't have health insurance and cannot get or afford proper medical care. Guidance from a doctor is advised. For those who can get azithromycin in countries without a prescription, caution is urged, especially if you have heart, kidney, liver, or bleeding problems. Doses may need modification. Why should we consider AFA therapy or similar treatment programs? Well, what's happening now in the world is a crisis. Current hospitalizations and deaths are very high in the United States, UK, and Europe. This problem gets worse after holidays, travel, parties, and get-togethers. Mutations will only add fuel to the fire. We will continue to have peaks and valleys for the next few months. Intravenous monoclonal antibodies treatment is costly. It costs $1,000 to $1,250, and this includes the product as well as the administrative cost. The supply is limited and it is impractical worldwide. Significant mutations may make this ineffective. Vaccination is not a treatment. I know I'm repeating this point, but this is important. It will provide desired immunity 2 to 3 weeks after the second dose. Current vaccination rate in the United States is slow, and to reach herd immunity, it may take us until late 2021. Mutations will dampen the protection from vaccine. New coronavirus mutations are occurring that are more contagious and probably deadly. What if a mutation in the near future makes the current vaccines ineffective, like the UK, Brazil, and South African variants? There are some additional problems. With 2 doses of mRNA vaccines, 95% efficacy is expected. Efficacy could drop to 90% due to logistical problems and multiple vaccines. That means 5% to 10% people could be at risk of getting severe COVID-19 despite vaccination. 5% of 330 million people in the United States amounts to 16.1 million, and 10% would be 33 million. There are people who do not want to take vaccine at all. Only 48.4% of adults over the age of 18 years took flu vaccine in the 2019-2020 period. The population at risk for severe COVID-19 in the United States and worldwide could be still large for months to come due to wait for vaccine, some people declining vaccination, mutations in the virus, and current efficacy of vaccines. The situation could be worse in developing or poor countries. Should those who get sick just wait and see, or try a reasonably benign treatment program with pre-approved medications? What do we have to lose? I would like to discuss some additional things. AFA therapy should be initiated in the early course of the disease. Pulse oximeter is a must to detect early hypoxia, especially in patients with comorbidities or pre-existing conditions. It could prevent deaths by early recognition of hypoxemia or hypoxia. AFA therapy may also prevent long-term debilitating symptoms in long haulers. AFA therapy may not only treat sick patients, but might even prevent and/or reduce hospitalizations and deaths. AFA therapy may even help during flu illness, thereby preventing more hospitalizations and deaths. PCR test results are not available for more than 48 to 96 hours after testing. Rapid PCR test is costly. Initiation of AFA therapy, especially in patients with fever, cough, and myalgia, seems like the most logical approach. Vaccination is not a treatment. It is for prevention and takes time to work to only help the one who gets vaccinated. While waiting for proven treatment or vaccination, should people suffer with sickness and die, or should they try a reasonably benign therapy like AFA? People and their doctors can be proactive and make their choices. What is AFA therapy or protocol? AFA therapy consists of azithromycin, famotidine, and aspirin. Azithromycin 250 milligrams, 1 tablet daily for 6 to 10 days with lunch. It could be modified to 2 tablets on the first day and then 1 tablet daily for 5 to 10 days. Famotidine or Pepsid, 20 milligrams twice daily for 14 days, in the morning and in the evening. Aspirin, 81 milligrams or 75 milligrams, 1 daily with food for 14 days for patients over the age of 45 years. Use of multivitamins, vitamin C and zinc as per personal preference. Do not use any of the above medication if there is history of allergy or contraindication. Doctor's guidance and supervision is advised, especially if there is history of heart, liver, kidney, bleeding, or stroke problem. Let's look at how synergy works in this AFA protocol. All the 3 medications, azithromycin, famotidine, and aspirin, work during phase 1 and phase 2 of COVID-19. All medications have anti-inflammatory effect. The cumulative effect is an important factor. On the practical side, some gastrointestinal side effects like nausea from both azithromycin and aspirin are muted or prevented by famotidine. Possibility of bleeding due to gastritis, esophagitis is reduced and prevented by famotidine. What are the do's and don'ts of AFA protocol? It is not for asymptomatic people even with a positive PCR test. It is only for symptomatic patients with positive PCR test or symptoms consistent with COVID-19. It should be started ideally within 24 to 48 hours at the start of symptoms. Doses should be modified as needed for patients with heart, liver, or kidney disease, or if history of bleeding or stroke. It should not be used if history of allergy or adverse effects to any medication in the protocol. It should not be used for prevention. The use of pulse oximeter, if available, is beneficial. Patients should get hospitalized if condition worsens. As I end this video, I would like to mention that the coronavirus image is courtesy of CDC. The slides and video were created by me, and the data on Indian patients was provided by Dr. Rajiv Prasad. Thanks for watching. Stay safe and healthy. Together, let's win the war on coronavirus.